Start whenever.
Hello, everybody. My name is Liz Speliotis. First and foremost, thank you so much for listening to my presentation, and I apologize for my shabby appearance. I just got home from instructing a class at my gym, so I'm very worn out this evening. For my presentation, I chose an article from the Wall Street Journal, and it's titled "The Talking Cure for Healthcare." This article was written by their assistant managing editor, Laura Landro. The article really touches on the benefits of therapeutic communication in healthcare in relation specifically to quality of care, driving down costs, and prevention of unneeded hospital readmissions, and of course, malpractice. So from a patient communication standpoint, it's also addressing the age-old complaints that patients encounter, which include a poor bedside manner by their physicians, revolving door practices by the doctors, and general lack of attention, and physicians that do not have very good people skills. Through training and a global focus from both hospital administrative teams and also the regulatory agencies, hospitals and healthcare systems have been focusing on retraining the old and revamping and updating the newer physicians in the system. Educational programs are also a big push, utilizing innovative approaches such as role-playing, actors perhaps doing secret shops at the doctor's office for review, and also a knowledge base around showing compassion, sympathy, empathy, and a general understanding of their patients and their morbidities and really how to speak to them. And the role-playing really plays a big part in that. Laura also discusses in her article that research has proven that when doctors don't listen to patients, they miss out on important health-related cues and have higher incidences of misdiagnosis. She mentions that barriers to communication are also a leading cause of regimen failure. Generally, if a patient doesn't understand the directions, they more often than not won't adhere or follow through on their treatment plan. Quality of care also comes at a cost to hospital reimbursements by governmental agencies and payers. So Medicare, as an example, will withhold payments for poor scores on patient satisfaction surveys. Recurring themes of hospital readmissions and reviews where the facility scored poorly on discharge directions are also items that get them penalized as well. Hospital administration's attention to the dollars and cents involved have been brought forth, and an increasing interest in general bedside manner and success in patient interactions, communications, and general delivery have also been a huge push. Interestingly enough, the article points out that malpractice attorneys also tout that a patient who has a good communicative relationship with their physician is more likely to not sue over a mistake or an overlooked detail. I found that fact to be very interesting as well. Globally, hospital systems are hiring companies that specialize in training for patient relations and communications between patients and practitioners. Educational institutions like Emory University School of Medicine are also focusing more on the later terms of medical school on incorporation of empathetic approaches and teachings. So later in the terms versus earlier in the terms, they're really working with the physicians in training to work on their communication skills and to really hone those focus areas. Physicians who have been in practice for many years are also being required to soften their approaches and think more patient-centrically. So some strength of Laura's articles would include that the patient satisfaction scores increased due to the training and the adherence to the plans and policies. And I really like that the percentages as the presentation of success rates were really forthcoming in showing optimization of these practices. Statistically also, there was great value placed on training and mismessaging by patients. Again, the numbers speak, and that's a pro because they can quantitate their successes and quantitate their failings. The numbers surely don't lie. Some of the weaknesses to the article is I felt like the article discussed major healthcare and communication amongst physicians, but it really didn't cover the administrative side and the feedback loop for supporting those physicians. It also missed addressing special populations and development of one-off programs to further facilitate better therapeutic communications amongst this population grouping. Another weakness I noted was that the quantitation was needed in looking at physicians from the older physician training models being introduced to the new wave of communication and training. And from a healthcare administration standpoint, it would have been interesting to see the results and comparatives between the newer physician training versus the older in terms of general patient satisfaction score variances. So to conclude this article review, I was really happy to see that in practice, therapeutic communication helps to bridge the gap in good versus poor care by practitioners and hospitals. It was encouraging that regulatory agencies provide third-party assessment of communication in regards to patient satisfaction scoring models and the penalties that follow. So a few questions for you guys to ponder and some food for thought. So question number 1. In your opinion, do you think that it's fair that physician reimbursements can be negatively impacted by patient satisfaction scores? So question number 2. Do you think it's fair to penalize a hospital for readmission based upon the diagnosis of the readmission? And question number 3. Do you truly think that there is a correlation between malpractice lawsuits and the physician-patient relationship? Thank you very much for listening to my presentation, and I hope you guys have a great week.